Special considerations. We're going to set this up like a standard robotic laparoscopy. Remember that significant blood loss may occur, and then we may do a transperitoneal or extraperitoneal approach. Most of the time for prostate cancer, we're doing a transperitoneal approach, meaning that we are actually entering into the peritoneal cavity. So differences in prostatectomy approaches, we actually talked about this already. Suprapubic prostatectomies are for BPH. A retropubic prostatectomy is for prostate cancer because we're actually removing the capsule as well as the prostate. So there is a risk of incontinence and impotence, but we try to use those nerve-sparing techniques to decrease those complications, and that robotic dissection has actually helped us to reduce those complications even further due to the fact that we can see better. Special equipment. We need our lap tower, which is part of the robotic system. Remember, we're going to have our console, our patient cart, and our robot itself. And then hemostatic device of choice. Once again, if we're using the robot, we'll be using their bipolar choice on there, but sometimes we do have a harmonic scalpel or a ligature on the field for the assistant to also be able to use as needed. Instruments that we need. We obviously need our robotic set, which includes our special camera and light cord and all those instruments that go with that. We need all of our Van Buren sounds so that we can actually insert those into the urethra as needed throughout the case. All standard laparoscopy access items for our special supplies, which includes our ports for the robot. Before there was the robot, we had these mini ports that you could access that were made the stab wound even smaller than necessary for what we need now. However, since the robot is becoming the standard of care, we don't use those mini ports an awful lot anymore. And then we need Foley catheter, probably several Foley catheters on the field because one of them may get nicked or cut. Medications on the back table, we need 0.25% Marcaine with epinephrine to block the port sites if we're able to do this robotically. So, anesthesia. Whenever we do a laparoscopic procedure, we have general anesthesia because insufflation of the abdomen makes the patient feel short of breath and like they're having difficulty breathing. So we always put them under general anesthesia. Positioning the patient, we're always going to put them in low lithotomy. We may use some Trendelenburg once we get them intraoperatively and see where their intestines fall. Positioning equipment, of course, we're putting them in low lithotomy. We need our stirrups of some kind and the connectors to connect them to the bed. Prep. We're going to do both a ChloraPrep and a betadine scrub. So we are going to do the ChloraPrep from the mid-chest to the mid-thigh, bedline to bedline, and then we're going to do the penis and scrotum with betadine, just to make sure that we're not getting any of that ChloraPrep on those mucous membranes. So draping, we're going to put a drape underneath the scrotum. We're going to put utility drapes around the abdominal space, towels around the perineum, and then most likely we'll use an LABH drape so that we have a clean area on the abdomen and a clean area down below for the penis. Our incision is going to be 5 ports, so we're going to have our camera here at the umbilicus and then 2 ports on either side to be able to reach the prostate. All right, our procedure step summary. We're going to insert our Foley catheter before we put our patient to, well, not before we put them to sleep, before we